Welcome to the deep dive. We've got a really fascinating one for you today.
Yeah, thanks for having me. I'm excited to get into this.
So today we are unpacking a dynamic that is right at the bleeding edge of fetal medicine. It's essentially a modern medical paradox.
Right, it really is.
Because right now, obstetrics has access to this revolutionary blood test. It's called cell-free DNA, or cfDNA.
hmm
And by just isolating these tiny fragments of a fetus's genetic material that are just floating around in the mother's bloodstream, this test achieves over a 99% detection rate for trisomy 21.
And it does that while keeping the false positive rate under 0.1%, which is just incredible.
It is. I mean, the precision of cfDNA has completely upended prenatal care. So here is our ultimate medical mystery for you today. If we have a genetic screening tool with that level of extreme accuracy, why on earth do clinical protocols still rely so heavily on these complex, highly operator-dependent ultrasound scans?
Yeah, that is the exact question.
If the blood test gives us the genetic code with near certainty, shouldn't early ultrasound screening basically be obsolete by now?
Well, that exact tension between genetic sequencing and sonographic imaging is the defining debate in first trimester screening right now.
Right.
And to fully grasp why the ultrasound remains the indispensable cornerstone of holistic fetal medicine, we really need to trace the evolution of diagnostic precision.
Okay, let's set the stage a bit.
Right. So if we look back to the 1980s, screening protocols were fundamentally demographic. The medical community relied heavily on maternal age as the primary risk factor for chromosomal anomalies.
Which wasn't exactly precise.
Not at all. That approach yielded a detection rate of roughly 30% alongside a 5% false positive rate. It was a blunt instrument. It generated a massive amount of clinical anxiety without offering much in the way of actual diagnostic clarity.
Okay, let's unpack this. A 30% detection rate means you are missing the vast majority of cases. So that shifted in the 1990s with the introduction of the combined test, right? Where they paired maternal serum markers with baseline ultrasound measurements, like Nuchal translucency.
Yes, and that combination brought the detection rate up significantly to the 85 to 90% range.
But, in the context of fetal development, a 10 to 15% blind spot is still highly significant. So what is the present goal? Where are you trying to go with this?
We want to close the gap. The present goal is to close that diagnostic gap entirely. Modern clinical standards demand a 95 to 100% detection rate while simultaneously suppressing the false positive rate below 3%.
Which is a tall order.
It is. And to do that, we need to go beyond the baseline. Relying on basic Nuchal translucency and serum markers simply won't mathematically get us to near-perfect detection.
Which brings us to the elephant in the room.
Let's hear it.
If cfDNA is basically a magic bullet, catching over 99% of trisomy 21 cases, shouldn't we just draw a vial of blood at 10 weeks and bypass the complex imaging altogether?
Well, if we connect this to the bigger picture, we immediately start to see the dangerous clinical blind spots of relying exclusively on a blood test.
Because it's not perfect.
Right. cfDNA is a phenomenal tool for comma and ploidies, but its scope is inherently limited. First, we have to consider atypical anomalies. Comprehensive data demonstrates that cfDNA protocols actually miss roughly a quarter of atypical chromosomal anomalies that a routine combined ultrasound screening readily catches.
Wow. 25% is a lot to miss.
Well, it's massive.
Yeah.
And second, there are just the biological limitations of the blood test itself. Clinics see a 1 to 5% no-call rate.
Meaning the lab just can't get a result?
Exactly. The laboratory cannot extract a viable result. This is really common in cases involving maternal obesity or when the blood draw is performed at a very early gestation, before there's enough fetal DNA present in the mother's circulation.
And I imagine waiting weeks for a critical genetic screening only to get an inconclusive result creates an immense psychological burden for expectant parents.
It's agonizing for them, and it leaves the clinician right back where they started. Furthermore, certain severe chromosomal abnormalities like triploidy are notoriously difficult for cfDNA to detect accurately.
But they show up on an ultrasound.
Glaringly. These conditions present with severe structural and hemodynamic abnormalities that light up clearly during a sonographic evaluation. But perhaps the most compelling argument for retaining the ultrasound is found in the persistent biomarker data.
What does that mean?
It means over 5% of fetuses who receive a definitive low-risk result from a fancy cfDNA screening still exhibit abnormal first trimester ultrasound findings.
Wait, really?
Yes. and those findings frequently require critical, immediate medical management.
So even with a perfect genetic screening, about 1 in 20 pregnancies still has a physiological issue that needs attention.
Exactly.
Okay, think about it this way. It's like having a flawless set of architectural blueprints for a house, but the plumbing was installed backward or the foundation is cracked.
That's a perfect analogy.
The blood test is the blueprint, right? It tells you what the genetics intended to build. But the ultrasound is the actual walkthrough of the physical house being built.
Yes, looking at the actual framing and plumbing.
So that naturally leads us into examining how doctors do that walkthrough. Let's look at the specific systems they evaluate, which the slides identify as the 3 pillars of secondary sonographic screening.
To understand how these 3 pillars function, we first have to look at the core mathematical principle behind them, which is the power of orthogonality.
The power of orthogonality. Okay, let me translate this for you, the listener. Think about securing a house. If you install 3 motion detectors pointing at the exact same hallway and one goes off, the other 2 will probably go off as well.
Because they're measuring the exact same thing.
Right. The information is totally redundant. But if you use 3 completely independent systems, say a motion detector on the door, a thermal imaging sensor in the ceiling, and an acoustic glass break sensor on the window, you have orthogonality. If one sensor goes off, it's a clue. If all 3 independent systems trigger at the same time, you have absolute confirmation.
And that translates perfectly to fetal medicine. The 3 secondary ultrasound markers we're looking at evaluate completely independent physiological domains. We have the skeletal system, the cardiac system, and the venous system.
Completely separate systems.
Right, because they develop independently. Finding an anomaly in one doesn't automatically mean there's an anomaly in another. Therefore, their predictive powers can be safely multiplied together without redundant information artificially inflating the risk score.
So let's dive into the first orthogonal marker representing the skeletal domain, the nasal bone.
Yes, clinicians are evaluating the early ossification of the nasal bone during that first trimester window. In certain chromosomal conditions, this ossification process is significantly delayed. So the nasal bone simply does not appear on the ultrasound.
And how predictive is that?
It's substantial. An absent nasal bone is observed in roughly 68.8% of trisomy 21 cases, 54.8% of trisomy 18, and 34.2% of trisomy 13 cases.
Okay, here's where it gets really interesting, though. There is a massive caveat here regarding ethnic variability, right?
Yes, this is absolutely crucial.
The baseline prevalence of an absent nasal bone is heavily dictated by maternal ethnicity. In a completely healthy euploid fetus, an absent nasal bone occurs in approximately 9% of Afro-Caribbean populations.
Right.
But if you contrast that with Caucasian populations, it only occurs in about 2.2% of healthy fetuses.
Exactly. So without mandatory ethnic-specific adjustments built into these risk algorithms, clinicians would systematically misclassify perfectly healthy Afro-Caribbean pregnancies as high risk.
Which leads to false alarms.
Huge false alarms. The algorithms must be calibrated to the patient's specific demographic background, otherwise you get unnecessary invasive procedures and extreme patient anxiety.
Context is everything. Okay, let's shift from the skeletal structure to the cardiovascular system. The second independent marker is tricuspid regurgitation.
In the cardiac domain, yes.
So tricuspid regurgitation, or TR, let's translate that. We are essentially looking for a leaky valve in the baby's heart, right?
Broadly speaking, yes. We are monitoring the tricuspid valve for a retrograde jet. That means blood flowing backward during the heart's pumping phase, or systole.
But the nuance here is in the strict diagnostic criteria.
Very strict. Clinicians aren't just looking for any backward flow. To be classified as an anomaly, the retrograde jet must last for more than 50% of the heartbeat. And crucially, it must reach a peak velocity of over 60 centimeters per second.
I want to clarify why that specific 60 centimeters per second speed limit is so important. Normal blood flow in a healthy fetal heart moves at around 50 centimeters per second.
Right.
If the doctors didn't enforce that strict 60 centimeter speed limit, a sonographer could easily mistake perfectly normal physiological blood flow for a catastrophic valve defect.
And that's exactly why the criteria exist, to prevent those false positives. When you apply that rigorous threshold, TR is found in 55.7% of Down syndrome cases, compared to just about 1% in normal fetuses.
But it's not just about Down syndrome?
No, it has a dual diagnostic role. This is vital. Even if the cfDNA blood test comes back showing perfectly normal genetics, finding TR is a massive red flag. It indicates an 8-fold increased risk of congenital heart defects, entirely separate from any chromosomal issues.
So the genetics might be pristine, but the cardiovascular plumbing is failing.
Exactly.
And you only catch that with the sonographic walkthrough. Let's bring in the final piece of the orthogonal trio. The third marker is the Ductus Venosus Doppler, representing the venous domain.
Yes, the ductus venosus is a highly specialized, critical shortcut blood vessel. Because a fetus receives oxygenated blood from the umbilical vein instead of its own lungs, this vessel acts as a bypass, shooting the most oxygenated blood directly through the liver and toward the brain and heart.
So when doctors use Doppler imaging to look at this shortcut, what are they searching for?
They're looking for abnormal flow. Specifically, signs that the fetal heart is struggling, which creates resistance that pushes backward into the venous system. They look for an absent or reversed A wave or a highly elevated pulsatility index.
And what does the data show on this one?
The predictive power is incredible. It shows abnormal flow in 69.1% of T21 cases, 71.9% of T18, and a massive 76.2% of Turner syndrome cases,
Wow.
compared to just 3.7% in normal, healthy fetuses.
So we have these three independent clinical triggers: delayed ossification in the skeletal system, a leaky valve in the cardiac system, and elevated resistance in the venous shortcut. How does the math actually work when you combine them?
It relies on the Bayesian multiplier. Individually, each of these markers generates an isolated likelihood ratio between 3.9 and 5.6, meaning finding just one multiplies your baseline risk by roughly 5. But because of that orthogonality we talked about, their complete independence, you can safely apply a synergistic multiplier. You start with the baseline test, and you mathematically multiply the specific likelihood ratios of any secondary markers you find.
And the result of that math is just staggering. By combining them, the detection rate skyrockets to between 96 and 100%, while false positives plummet to between 2.5 and 3.5%.
It essentially achieves the perfect clinical mandate we discussed at the start of the deep dive.
It's mathematically perfect, which forces me to ask the obvious question. If integrating these three markers creates such an amazing diagnostically superior profile, why doesn't every doctor just do them on every single patient?
Well, that is the cost of precision.
Operator competence.
Exactly. These scans are incredibly difficult to perform. Accurately measuring the ossification of a nasal bone on a fetus that is literally centimeters long while it's actively moving around requires an elite level of sonographic skill.
The slides detail just how operator-dependent this is, right?
Yes. The nasal bone has the highest operator dependency and only moderate inter-observer agreement. To even get certified to perform this specific check, a clinician has to submit a log of 120 rigorously supervised scans.
120 supervised scans just to be trusted to spot a single millimeter scale bone.
Right. And the ductus venosus is similarly demanding. It has high technical difficulty because doctors have to avoid a V-shaped artifact contamination from neighboring hepatic veins. That requires 80 supervised scans for certification.
And tricuspid regurgitation.
Luckily, TR is highly reproducible with excellent agreement between doctors, but it still requires specific Doppler training.
So there's a massive clinical warning attached to all this mathematical perfection.
Yes, the warning is skill decay. If these scans are done in non-certified settings or by operators who are out of practice, the skill decay rapidly offsets all the theoretical mathematical gains we just talked about.
Because if the raw sonographic input is flawed, multiplying it just amplifies the error.
Exactly. A high false positive rate from bad technique leads to unnecessary invasive diagnostics, which defeats the entire purpose of the screening. And the reality is, the healthcare system physically cannot supply enough elite specialists to perform these deep Doppler evaluations on 100% of pregnant women.
So what does this all mean for the patient? How do doctors actually deploy this without collapsing the medical system?
The solution is the contingent screening model. We have some brilliant 2024 data from the Fetal Medicine Foundation based on over 19,000 pregnancies that outlines this new paradigm.
Okay, break down the stages for us.
Stage 1 is universal. Everyone gets the first-tier combined test. From there, the population is triaged. If your baseline shows you are high risk, meaning a probability of 1 in 50 or worse, you bypass secondary screening entirely and go straight to invasive testing like CVS or an amnio.
Right, because the risk is already clear.
Exactly. On the other hand, if you are strictly low risk, better than 1 in 1,000, you go directly to routine surveillance.
Which provides huge psychological relief.
And frees up massive clinical resources. The sweet spot of this model is how it handles the intermediate risk group. That's about 15% of the population.
So that 15% is where the system concentrates its advanced tools.
Yes. This is where you deploy the expensive cfDNA blood test or refer the patient for those highly specialized secondary sonographic markers.
And the result of that strategic triage.
A 96% detection rate and only a 2.4% false positive rate across the board. It gives you universal level efficacy without overwhelming the system.
So let's look at some actionable clinical management. Just to show real-world application, let's fire off how doctors handle specific abnormal findings.
Sure.
If the baseline sonogram shows a Nuchal translucency of 3.5 millimeters or greater,
That overrides everything. The patient goes directly to invasive testing.
what if they find an isolated absent nasal bone?
The clinician's first mandatory step is to apply the ethnic correction factors. If the risk remains high after that adjustment, the protocol dictates using cfDNA.
And if they find any tricuspid regurgitation finding,
The pathway pivots to cardiology. Because of that eightfold risk for heart defects, finding a retrograde jet mandates an early specialized fetal echocardiogram.
and finally an abnormal ductus venosus flow.
That requires a triple assessment, a genetic evaluation, an early fetal echo, and longitudinal surveillance. Because early venous resistance is a strong predictor of late-term placental dysfunction or restricted fetal growth.
So if you pull back and synthesize all of this, the narrative is crystal clear.
It really is. These secondary sonographic markers, the nasal bone, the tricuspid valve, the ductus venosus, they aren't just archaic fallback genetic screens for when blood tests aren't available. They are comprehensive early health indicators.
Right.
In this modern era of highly accurate blood testing, rigorously assessing these specific physiological markers remains the ultimate cornerstone of holistic, fail-safe first-trimester fetal medicine.
It perfectly illustrates to you, the listener, that having the most advanced genetic blood tests in the world still doesn't replace the immense value of a highly trained medical professional looking closely at how a tiny, developing physiological system is actually functioning.
You still have to look at the house being built.
Exactly. Before we wrap up this deep dive, I want to leave you with a final provocative thought. We spent a lot of time discussing how the biggest bottleneck to this incredible screening is human operator skill. The fact that a clinician needs 120 supervised scans just to reliably spot a nasal bone.
A huge barrier.
So considering the staggering pace of technology right now, how soon will it be before artificial intelligence and machine learning are integrated directly into ultrasound machines? Imagine an AI overlay guiding a routine technician's hand in real time, calculating those retrograde jet velocities instantly, effectively democratizing this expert-level precision for every single pregnancy around the globe.
That would change everything.
It's a profound shift in global healthcare access to keep an eye on. Thanks for joining us, and we will catch you next time.